very much. I'll see if I can work the magic lantern. Okay, what I'm going to talk about today is a little different. The fact that traumatic brain injury is not in your head. People will always hear, it's all in your head. Well, in fact, it is an injury, and it ain't all in your head. Let's look at the evidence for that. Wonderful. So, given my love of railways, you'll not be surprised that I'm going to cut into the story of what brain injury is all about. It's been described for many, many, many years back in the Greek times. But in this case, we'll go through, we'll cut in at 1867. Now, at that point, railways were not quite what they are today, although having just traveled down on via, it may be not too much different. What happened in the 1850s in Britain, railways were spreading everywhere, and they spread a little faster than confidence of drivers, and they spread a little faster than braking systems. And so there were a lot of bumps, and these bumps really caused a lot of problems. What Erickson found in his book was that if you were sitting, that's a very early locomotive, that's rocket. So they were a little more advanced than that, and I don't have any from the 1850s because there are none preserved. The things are crude. This is a very early second-class coach. You'd sit out in the open, and if you were sitting forwards, you would do a lot better when you have one of these bumps, which are frequent, than if you were sitting back. Now we understand that that is in part due to the neck. The mechanics are very simple. The neck moves a little bit. If you hit something and your head goes forwards, whereas if you got hit from behind, then bad things happen because your neck really expands. And that causes a lot of problems. I'm not going to be talking about a lot of whiplash today. That's another topic altogether, but it's very important. It also means that the brain gets a little bit more adult by shaping it through a larger range of motion. Now, Page, shortly afterwards, talked about spine and spinal cord and nervous shock. And he was a railway surgeon. I want you to know that, because people through Erickson's cases said, if they hadn't sustained a really obvious spinal or nerve injury, then the symptoms were psychogenic. And we call it neurasthenia or hysteria. A reminder to remove my mask. Okay, so this was very important because he was paid by the railways and they were defending their cases. So this was really the first example of a defense medical report. I hope you can understand that things have not changed in the last 200 years or 150 years. Then we come to Jean-Martin Charcot, very famous neurologist, who, without really going into this very much, said this was all hysteria. So what about symptoms after an MTBI, and they have a lot? We know 15 to 20% don't recover. And what do we see as risk factors for this? Well, first of all, pre-injury history, psychological disorders, migraine, headache disorders, prior concussion, socioeconomic factors, and educational level, being female, and older age groups, and that's been mentioned earlier today, as well as a personality type. Now, after the person's had an injury, look for high symptom severity, headache, dizziness initially, and a high number of symptoms reported early. Bad prognosis. High dizziness, balance rating, and development of depression, anxiety, PTSD. I put litigation as a question mark there because really litigation has been looked at many times. It does not really seem to bear out as an affecting factor. So we came upon some questions back early on, and Journal of Neurology and Neurosurgical Psychiatry, 2008, Mears and colleagues, very good collaborators, Bryant and Bailey, from Australia, had looked at a series of patients, and they found similar symptoms of post-concussion were found in mild traumatic brain injury and non-brain injury orthopedic groups, which is very interesting. And they found no specificity to MTBI. In fact, the similarity between orthopedic injury and brain injury was remarkable. So we looked at this in our own group. We analyzed 108 recent patients, and with Shazia Malik, my graduate student, Teresa Mali, the nurse, Rahim, student, and I, we found that about 20% of patients referred to us did not meet ACRN criteria from 93, which is the older criterion. And no symptom-specific differences were found. So if you met ACRN criteria or didn't, there was no difference. And with upgraded criteria, some of these patients would have been categorized differently. But we thought at the time, well, could there be some underlying symptoms that would, or mechanisms that when you break your leg would give you the brain symptoms, or when you break your brain would give you the same symptoms. So we thought about that. And at the time we said, well, it's well known that even a whiplash injury will elevate some inflammatory cytokines. Inflammatory cytokines are proteins that we see in all sorts of inflammatory disorders. And they certainly affect brain. So we said, hypothesis, perhaps they're related. And could brain trauma and systemic trauma have similar mechanisms? So, our first paper was written, actually that's my son, he's a writer at Rathbone, and he's now doing physical and rehabilitation medicine as a consultant at the Queen's. We looked at the evidence for this. What we found was that systemic inflammation might be involved, and cytokines we proposed as mediators. So we said concussion or systemic injury produced neuroinflammation. And then we looked at various of these cytokines, at dizziness, headache, depression, reduced tolerance, sleep disturbances, cognitive difficulties, fatigue, irritability. All of those are associated with increased cytokines that have been reported, which is very interesting. These are cytokines that are not how people feel, but what they've got in their blood. So we then looked at the correlation between mild traumatic brain injury, inflammatory cytokines, and emotional symptom traits. Just to go a little bit further, because we know that emotional symptoms, as we heard this morning, are absolutely key. So there was a positive correlation in IL-6 and TNF-alpha and PTSD and chronic MTBI, and elevated IL-10 and CRP associated with PTSD and depression. And we even speculated these could be potential biomarkers, but we won't even go there. Biomarkers are a difficult area. So we then looked at inflammatory cytokines, mild traumatic brain injury, clinical outcomes, and did a systemic review and meta-analysis. Meta-analysis turns out to be very difficult in this field. Then we said, well, we found within 24 hours there was evidence of post-MTBI having significantly higher IL-6, IL-1, interferon gamma compared to healthy controls, and after one week, the CCL2 was going higher, which was interesting. And then after that, a whole number of things, including CCL2, were higher. So there's now an evidence that the type of inflammation changes with time after an injury. Some are up earlier, some are later. And then we said, well, what have other people found? Well, cytokines in primary headache disorders, and certainly those are well known. And it's the same cytokines. How about inflammatory cytokine levels in migraine? Yes, absolutely. So we see the higher levels in migraine patients compared with healthy controls. And how about depression? The other sort of thing we've heard today is very, very important. So the answer is yes. Again, cytokines are very important. Then, association between meta-analysis and inflammatory disorder and generalized anxiety disorder. CRP higher, which is a general inflammatory marker, but suggested that was an inflammatory response. MRI correlates of chronic symptoms in MTBI. We had imaging differences, and I draw your attention to the symbol of it, Tanya Rex, who is a goddess of things I in the US. She's on all the review boards for NIH and so on. Very smart lady. So she has been involved in that, and like us, we've spent quite a time discussing with her. We think that inflammatory changes are very important. Now, what about treating inflammation? Well, we know aspirin doesn't work because everybody takes aspirin today, or one of the other non-steroidals. for their headaches. But we were thinking, well, if you treat too early, then there is reason to get inflammation. There's good inflammation, which helps you recover from a wound. And then there's bad inflammation, which keeps on going on when you don't want it. And it's the bad inflammation we want to try and stop, not the good inflammation. So we thought timing was very important, but treating chronic inflammation that correlated with prolonged symptoms after MTBI was probably going to be a good idea. Now, when we're treating, we just heard that neurological treatments, musculoskeletal treatments, mental health treatments are very important, and then we have novel treatments. So there's no magical treatment for TBI. Education, first of all, positive reinforcement. Active evidence-based treatment of symptoms. The headaches, vestibular therapy, physiotherapy for the neck. Graduated return to all activities as soon as possible. Address comorbidities, such as other pain conditions, psychiatric disorders, and socio-economic issues, though those are very hard to treat, as you know. And then we try to address the patient's perception that they have serious brain damage. Because patients will come in, and I try and see my patients within, if they phone the office, we have an arrangement to see them in what we call the Green Bank Clinic. We'll see them within 72 hours. If, however, they have had, this is the third consultation, and they've had this for several years, then they go into a long waiting list. But we try and get patients who had an immediate injury treated right away. And everybody who comes in seems to have been told they had a serious concussion. So we take a very good history of the concussion, see what it's all about, and go from there. See what the symptoms are. So, essentially, active treatments don't delay or wait for symptoms. Now, headaches. This is something that neurologists have quite a bit to do with. Migraine, tension type, cervicogenic, from the neck, from the whiplash, and from medication overuse, which unfortunately is about 80% of the headaches we see have medication overuse headaches. Using analgesics more than 10 days a month for more than 3 months will give you rebound headaches, and headaches come back essentially looking for more meds. So you get more and more headache, and it tends to develop into a chronic daily headache, which is quite difficult to get rid of. So we treat with a prophylaxis wherever possible, and the prophylactic agent is determined by various other issues that was just referred to by the previous speaker. Another thing we try and get rid of is the risk of kinesphobia that I want to move. Central sensitization we're worried about because this can transform to a chronic headache. Whenever you have pain, the pain is recorded in the brain. And there's now very good evidence that when you get pain somewhere, the area receiving that pain in the brain spreads. And in fact, my friend and colleague Dinesh Kumbhari in Toronto has got some beautiful pictures, which I saw the other day, when his knee was hurting. There was enormous spread of the receptive field for that knee on a functional MRI. So yes, it's a real thing. The brain does change, and that is the central sensitization. So, prophylactic medications, that's already been mentioned, so I won't dwell on that. The thing is that we have to use some of the oral agents before we can go to the nice effective CGRP antagonists, because nobody will pay for the CGRP antagonists, which are quite pricey, until you've used the cheapies that may or may not work as well. So, the other thing we can do is trigger point injections or occipital nerve blocks for a patient who's got typical occipital neuralgia from the neck, radiating up the back of the head, and then culminating eventually in a migraine headache. And non-pharmacological management is very important. Physical therapies, including physiotherapy, nutraceuticals, yes, some of them do work, acupuncture, and headache hygiene. We give everybody who comes in with headaches a little sheet actually, of headache hygiene things that they can do to generally reduce the number of headaches. And if you want a sheet, email me. It's an easy email address. My name, Michel Rathbone, at michelrathbone.ca. Now, while we're talking about headaches, talk about inherently photosensitive retinal ganglion cells. And these are non-image producing cells, some of these. So that you stimulate them, they don't produce an image, but they do go to various areas of the brain. And again, Tanya, Rex, and her team have suggested that there's an underlying connection between them and various symptoms. And they're probably right, because if you look at the pathway, they go to various areas, like a lot of areas in the brain, including the areas that subserve functions for mood, subserve functions for pain, etc. So her hypothesis is that the retinal ganglion cells, and particularly inflammation of those, which would fit with our information, is responsible for many of the symptoms of concussion. Now, another thing I'd like to talk about is light emitting diodes. Now, this was discovered in the US, Arizona. We published a crossover trial. We tried this on animals, shown that exposure to this wavelength of green light reduced pain response. Then they tried it on people, and they found it also worked. And they did a crossover clinical trial to demonstrate that it really was effective. And again, they thought that it was mediating through IPRPC. Now, we were talking about what to do with a person who's got photophobia after head injury, and a lot of people have photophobia after head injury. So what we use is FL41 lenses. FL41 filters block out blue light. Blue-looking glasses, or something so faint, don't work, trust me. So you have to use that particular filter to block out the obnoxious blue wave. My story is be very careful about the insurer, because we put in the OCF 18 for this for one of our patients, and the insurer came back and said, we'll do FL41s, but we found a much cheaper source. Beware. So they gave the patient to us. The patient came back to see us in a week and said, I can't use these. Why not? Well, I can't see the green on the stoplight. I said, nonsense, it doesn't block green. Put them on. Guess what? It blocks the green. It was useless. I don't know what filter they were putting in, but it was cheap, it was useless, so I had to write back to the insurer and said, I'm sorry, you saved yourself some money, but it'll cost you more money now. So these have been demonstrated in clinical trials to go quite well. And the other thing is, people who want to put themselves in a completely dark room, we've seen that a lot. I have to explain to them that, well, what they're really doing is, in fact, the reverse, because when you're in a dark room, think about it, what happens in a very dark bedroom and you turn on the light? Big alley. And this is exactly what happens, because when you go into a dark room, you can't see anything, then you can gradually see things. Because the visual system ups its gain in the eyes and the brain. And you don't want that. You want a normal gain, or a reduced gain. I use a gain of the electrical sense. Now I'm going to talk a little bit about psychological symptoms. And psychiatric problems, pre and post-injury, are the most robust and powerful predictor of poor recovery. And I explain to my patients, look, if you've had any of these things, such as anxiety disorder or depression, before you hit your head, it'll be worse enough. And if you didn't have them before, you will have them after, because we see this, we look for it, and we do an inventory, a standardized inventory that's acceptable on each of our patients. But this has been demonstrated, and broad spectrum like neuropsychiatric disorders in adult personnel also confirm this. So potential psychological symptoms of depression, anxiety, emotional difficulty, etc., and catastrophizing. High risk of mental disorder after MTBI. And we feel it's important to identify and address early on all of this. Now, this leads us to a big pharmacological treatment we can do through the clinic at the first level. Psychiatry is very difficult to get, at least in Hamilton. And funding for good psychological CBT, which is first line of defense and is probably as good as drugs, is not always easy to get through the insurer. But CBT is one way to go. And exercise now has been shown to be very effective, and probably as effective as most things. So, antidepressants and monotherapy. We like that. Remission rates, identical. Running group outperformed in physical activity, in physical performance, heart rate variability, blood pressure, and while there's a deterioration in physical health, increase in weight, increase in CRP, that's inflammation, and borderline increase in diastolic blood pressure and triglycerides in the antidepressant treatment group, but not in the exercise group. Now return to work following traumatic brain injury. And this is absolutely key because after MTBI, half of the patients did not return to work, 1/3 returned to work with a limited capacity who had the psychological problems and deficit in attention, depression symptoms significantly associated negatively with return to work. And depressive symptoms were significantly independent predictor of return to work. So treat the depression. If you want to get the patient back to work, treat the depression. Okay. I just want to tell you about some interesting things. Now, brain fog. I'm showing all no patients reported brain fog after the TBI and associated with greater depressive symptoms and slower processing. So, how do you treat fog? It's an inflammatory condition. For example, it's been seen in COVID-19, and cognitive complaints are associated with it. Cognitive rehabilitation accommodations can be done for it. OT, speech language pathology, exercise, restorative sleep, and nutrition. And if the symptoms worsen, consider other factors. Now, I want to introduce you to our little magical maneuver. See that up there? Anyone know what it is? You must do. Yes. It's our friend, lion's mane. And oral intake significantly improved cognitive function and prevented cognitive deterioration in studies. And it does so through a pathway activating O1-2 proteins, and they're triggered by BDNF, brain-derived neurotrophic factor. And that was shown, brain-derived neurotrophic factor over here goes through the membrane, not like nerve growth factor, but whereas nerve growth factor stimulates the growth of pain neurons, this does all the other good neurons. So BDNF, new neural connections, neuroprotection. And what role does it play after brain injury? Well, 8 weeks of oral lion's mane, decreased expression, anxiety, and sleep disorders, supplementation, decreased depression, anxiety, and sleep disorders, and pro-BDNF levels increased. Then the next thing about BDNF is that we're very interested in it, but how do you get BDNF otherwise? Well, you in fact exercise. Short bursts of high-intensity exercise are more effective than continuous high-intensity exercise elevating BDNF. And 73% prefer the high-intensity interval training protocol. And that's very important. And I'll tell you what we use. Again, now, plasma BDNF is correlated with circulating lactate. Lactate is something you see when people exercise very hard. And it appears that exercising very hard, we don't know whether just lifting a weight or two will do it. It probably will. But certainly otherwise exercising will improve things. And the important part about that is that the BDNF, like exercise, didn't affect it. But you have to do high intensity exercise, and it's probably related to getting more evidence on this. It's probably related to dietary treatments don't really affect BDNF. That's something like that. Anyway, what we have found is when we treat patients, we can use high-intensity interval training when we've got a specific treatment. We use 3 20-second bursts of activity with 10 minutes recovery in between. So 20 seconds, 2 minutes recovery, 20 seconds, 2 minutes recovery, 20 seconds warm down. That's all. How intense? Well, as intense as you feel. Patients know much better what intense is than we can determine. That usually does not give headache. It does not increase headache symptoms, providing we don't do it in running. Running or jerking. But there are many other activities will work very well. 3 times a week maximum for various reasons I can discuss later. We don't do it more, but basically exercise is inflammatory, recovery is anti-inflammatory. You need to do the exercise to get the anti-inflammatory recovery, so that's what we do. We need a day in. That has been shown, in fact, to improve cognitive function in regular people. And I'll just tell you that we have, by combining both lion's mane and that high-intensity interval training, we've had several people on it, and a good proportion come back and say, incredible, my brain is clear, I have no more fog. How long? 2 weeks, which is really, really incredible. There was no other treatment. Now, everybody is dizzy after a concussion. And what we can do, we can look at central vestibular, within the brain, peripheral vestibular, and it can be both. Fortunately, in Hamilton, we have an expert in dizziness, an ENT surgeon, who's our dizzy doc, and he does all the careful type of testing. There are very few dizzy docs around, unfortunately. But we have to look at other things such as medication, anxiety, blood pressure regulation, and we have to check whether the person really is dizzy or whether they have developed an ataxia, which is a wobbly gait. So the treatment of that will depend on the type. I don't have time to discuss this in detail today. So, sleep disorder, another important problem. Reinforced sleep hygiene. Don't use benzos. Consider melatonin and CBTI, particularly CBTI. Melatonin will only help you get off to sleep initially. Use good Canadian melatonin, regulations for material, including the lion's mane from Canadian sources are much, much stricter than those in the US. So you have an idea that what you're paying for is what you get. So medical intervention, you can use those. So hopefully not. If things persist for more than a month, we send for a sleep assessment and sleep study with our experts. Finally, other comorbid conditions such as musculoskeletal. This is common sites of problems, neck pain, persistent pain, or pre-existing chronic pain, and they're probably being augmented through the same mechanism that I mentioned earlier in the brain. Cervical radiculopathy will again do this. Carpal tunnel syndrome can be made worse. So you have to look at those. Normal treatments and assessments. First of all, QEEG, which we're using to monitor patients and monitor production, monitor their progress. We've got a helmet there which we use as an EEG, and we work with Korea, and we get our results back in real time. We can do hip training. We always use omega-3s, particularly high DHA, not EPA. And these, turns out, become resolvins, which are probably the actual molecules that are effective. We use resveratrol. Melatonin has been shown to reduce inflammation, work as an antioxidant, N-acetylcysteine, helps mitochondrial function. Statins I've not been impressed with, although they're said to reduce inflammation. Lion's mane, and a number of patients on their own have tried HBOT, some with success, some not. I don't know whether that works or not. There's really good indicators it probably does. So that's very briefly some of the novel treatments that we're using. And I thank you.
Any questions for the doctor? Right here. How many intervals do you recommend for the weight training? So you've got 2 minute intervals, 20 seconds, 3 minutes.
It's 3. Warm up, 20 seconds, 2 minutes, just slow movement, 20 seconds, 2 minutes slow movement, 20 seconds, and then a warm up. 3 times a week. That's all. As I say, the intensity is determined by the individual. I learned that as a track coach many, many years ago. The athlete knows far more than the coach about their body's